Okay, here we are again resuming our session, and we stopped at the tranexamic acid and how it works. And tranexamic acid is capron. Tranexamic acid is one of the most important agents in the management of postpartum hemorrhage, and of course, it's one of the agents that you can use for HMB. How it works? Tranexamic acid, as you can see, is amino acid lysine derivative, and that means that it can bind to the lysine binding sites. One of the lysine binding sites is plasminogen. Plasminogen have to convert to plasmin, and plasmin is going to break out the clots. So if I can stop the transformation of plasminogen to plasmin, I can protect the clot. This is how tranexamic acid works. It helps to protect the clot being together. It is anti-fibrinolytic. Anti-fibrinolytic. So all of those can come in your question. It inhibits plasmin formation, yes. It inhibits the conversion of plasminogen to plasmin, yes. It is anti-fibrinolytic, yes. All of them are true. They also discovered that it partially inhibits fibrinolysis at higher concentration. This is what I mean with anti-fibrinolytic. So it has like three mechanisms of action. It can inhibit the plasmin directly, or it can inhibit the formation of plasmin. And again, I'm reminding you, plasmin, what is the work of plasmin? Plasmin is going to cause degradation of the fibrin. So it's like I'm protecting the clot integrity. I don't want the clot to be disintegrated. This is what tranexamic acid work, how tranexamic acid work. The next one in the management of HMBs, the non-steroidals. And some may wonder how non-steroidals can be used to decrease bleeding. We know that this is anti-inflammatory drug. From its name, it's called non-steroidal anti-inflammatory drug. They call them so because the chief anti-inflammatory is the corticosteroids. So when we discovered other agents that can be anti-inflammatory, we call them non-steroidal. Okay, so we still want to know how they would affect bleeding. Let me tell you the story from the beginning, okay, because this is important for your exam. We have a very, or let me, I cannot describe how important arachidonic acid is in our life. Arachidonic acid is omega-6 fatty acid, and it's present in the cell, and it has a strong linkage to carcinogens and inflammatory process inside the cell. Okay, so arachidonic acid has a way to work. It works by two enzymes, COX-1 and COX-2, cyclooxygenase enzyme. When it works on those enzymes, it produces other agents. The agents are thromboxane E2, prostaglandin E2, prostaglandin I2. So those agents in general have a mechanism of action. What they do, they are essential for many things in the cell, like mucosal protection, like keeping the renal blood flow good, like platelet aggregation, keeping the health of endothelium, like angiogenesis, cell proliferation, macrophage proliferation, um, vasodilatation, vasoconstriction, each according to its job. So, okay, now I have discovered something to inhibit the COX enzymes. Those are the non-steroidals. Non-steroidals work by inhibiting COX-1 and COX-2. So now I'm going to prevent the formation of the important agents inside the cell. And yeah, I will lose their important function, but at the same time, I'm going to inhibit the inflammatory process because, as you can see, they are pro-inflammatories. So in one way, I'm losing some of the functions of those prostaglandins, and on the other way, I'm getting my desire. I want to stop the bleeding, right? So let's see how it's done. We have the COX inhibitors. COX inhibitors are the non-steroidals. So all of them work on both of them? No, we have selective and non-selective inhibitors. So selective inhibitors mainly work on COX-2, while non-selectives work on both of them. This is important for your exam because they love to ask you which one is selective, which one is non-selective. Aspirin and non-steroidals are non-selective COX inhibitors. They work on both COX-1 and COX-2. While the selective COX inhibitors like celecoxib or revcoxib, which, by the way, one of my favorite agents in treating bone inflammation and joint inflammation, um, they work only on COX-2. So, okay, you are going to prevent this enzyme, so you are going to prevent the formation of prostacyclin and thromboxane A2. How this is going to work for me? Prostacyclin I2 is a vasodilator and it inhibits platelet aggregation. So if I give the woman non-steroidals, I'm going to somehow prevent the vasodilation and resume the platelet aggregation, right? While if I give her uh, uh, the non-steroidals and the aspirin, I'm going to prevent the thromboxane A2. So I'm going to have vasodilatation again. And the promotion of platelet aggregation, it's going to be stopped. So, what is this? It's like I'm having vasoconstriction one way, vasodilatation one way. This one inhibits platelet aggregation, and I just stop this. This one promotes platelet aggregation, and I just stop it. Yes, yes, this is how it's done. Collectively, we're going to have uh, promotion of platelet aggregation because the way the non-steroidal work is non-selective. So when they inhibit both of the enzymes, this way is stronger. So I'm going to promote platelet aggregation as a result, as a result. And this is how they are going to help me in something like HMB. Aspirin, on the other hand, is very unique and in low doses, and this is why if you can see the difference between prescribing aspirin for someone, we want to give him maintenance for prevention of clot formation, and aspirin in high doses as an anti-inflammatory, and we always warn the patient about the risk of bleeding, right? So aspirin in low doses to prevent clot formation. Aspirin in high doses work as anti-inflammatory, and at the same time it can cause gastric ulceration, of course, and it affects the renal blood flow, and it may cause hemorrhage, right? However, if you can remember, aspirin should not be stopped before any surgery. It can be safely taken until the time of surgery, not going to cause bleeding during surgeries. Remember this. Okay, this was a recall before. I wanted to stress on it. because they, as I told you, they asked about which one is selective, which one is non-selective. Take care that aspirin also, because I told you it's unique because it's irreversibly inhibits both COX and COX-2, and it inhibits COX-1 more than COX-2. This is also important for you if you are thinking why or how the action is done, while it seems there's contradictions between the actions. If you know the details, you are going to get it. And still, we are figuring more and more out about them and how they work. Okay, now turning to antihypertensive agents. And of course, you all know that propranolol is our favorite, or let's say labetalol. Labetalol is our favorite in treatment of hypertension and preeclampsia during pregnancy. Next to them would be the alpha-methyl dopa. Alpha-methyl dopa is centrally acting sympathomimetic. And as I always say, when you have a central acting agent, you always fear of side effects. So yes, alpha-methyl dopa is not our favorite, especially postpartum, because it can cause postpartum depression. We also have the angiotensin inhibitors, angiotensin 2 inhibitors. Uh, they are not our favorite in pregnancy. They are contraindicated. The prazosin and doxazosin, the specific alpha-1 receptor antagonist, is not famous during pregnancy also. Hydralazine, which is direct vasodilator, can be used in severe cases and acute preeclampsia. The angiotensin converting enzyme or ACE inhibitors like captopril also cannot be used in pregnancy. The calcium antagonists like verapamil, nifedipine, all of them can be used during pregnancy, and we still use them for preterm labor, also to decrease the intensity of contractions. Those are exam questions for sure, and you should know labetalol contraindications, because as it is the first agent that we resort for to treat the hypertension, you should know that it is non-selective. It works on beta and alpha adrenergic receptors. So I'm expecting to see some side effects. The most important is asthma. So this woman, if she is asthmatic, she cannot use labetalol because they are causing bronchoconstrictions. If this woman is having congestive heart failure or hypotension or cardiogenic shock or something with her heart like third degree or second degree heart block or severe first degree heart block, labetalol also is not going to be her friend. While nifedipine or verapamil, calcium antagonist, is going to work just fine with those layers. So just for you, for the level of part one, you should know the mechanism of action, the side effect, and the name of receptors, if any, and the contraindications. Anti-epileptic drugs, guys, is very important in your exam because, as you know, they have teratogenic effects, and this is mainly what comes to part one. So we have several anti-epileptic drugs, and something is related to anti-epileptic drugs also, not only the teratogenicity of them, but also the interaction between anti-epileptic drugs and contraception. So this is like every exam question. So we have some famous anti-epileptic drugs. like sodium valproate or carbamazepine. So those in particular can cause neural tube defects and spina bifida. Why? So in general, we should know that when we use a monotherapy, like one agent only to control epilepsy, this is much better than using multiple agents. And the risk of teratogenicity, of course, will rise with the combination of the use of more than one drug. Okay, so we should know which agent is safe during pregnancy, which one is totally contraindicated during pregnancy. Something like phenytoin, valproic acid, carbamazepine are usually safe. Take care, there is a difference between sodium valproate and valproic acid. So here is the table from our talk article, and the percentage of teratogenicity still come in the exam. They love to ask you about the monotherapy risk and the polytherapy risk, and the polytherapy with valproate specifically can rise up to 10%. So, of course, if the woman is controlled on one agent or more, it's not good practice to stop them during pregnancy, even if the agent she is using is teratogenic. You should continue and make a good surveillance for her and her baby. So the safest agent, which one? Which one is the safest agent during pregnancy? This would be levetiracetam. Levetiracetam is usually safe. It's only 1 to 2% risk of congenital anomalies. Okay, and it is not dose dependent like lamotrigine. Lamotrigine is very safe also, but it is dose dependent. So this is why if I'm having a question that asks me what is the safest agent or anti-epileptic drug during pregnancy, I would choose levetiracetam, of course. We have also phenytoin. Phenytoin is really safe. The carbamazepine also, yes, it can cause cardiac defect and it can cause neurological defect, but still considered safe. And it's still, again, it's dose dependent. So guys, please take care of the percentages as much as you can. You should know the possible congenital malformations, the percentage or the risk with monotherapy and polytherapy, which one is the safest one. In part two, inshallah, we are going for much details about the effect of anti-epileptic drugs on the growth of the baby and the neural development of the baby. Here is a very important question. Which contraception should be offered to women who are taking anti-epileptic drugs? Generally speaking, copper iodine is the best. Definitely, okay, because it's non-hormonal. However, those women may need general anesthesia to insert copper iodine or Mirena because the pain during the insertion of IUDs can cause infects. So if we are talking in general, we can offer any woman who is taking non-enzyme inducing anti-epileptic drugs anything. We can offer them anything. Why? Because, okay, there is no interaction now between the anti-epileptic drug and the contraception. While if she is using enzyme-inducing agent like carbamazepine, like phenytoin, not every contraception is going to work for her. So what should I offer her? I should offer her something which is long-acting, okay? I should get away from COCs, anything that contains estrogen. So I'm left with copper IVs, Mirena, Dempa, okay, the injection or the implant. So yes, those are not affected by the enzyme-inducing agents, and I can offer them all. I can offer her all of them. Okay, again, what would be the question in the exam and how I'm going to answer it? the best agent for epileptic patients is DEMPA, the injections, or the uh, medroxyprogesterone acetate injections. Those guys have been proved to decrease the incidence of fits also. So this is why they are the best for her. If she optioned for a copper IUD, okay, but she should know that this is not going to be inserted in the outpatient clinic. She will need general anesthesia. Okay, so for the exam, the best agent for epileptic patients would be DEMPA. I want to talk more about enzyme induction. So you get the idea of enzyme induction. Um, to ask about why would phenytoin or carbamazepine, when given with COCs, they are going to interact together, or why they are contraindicated together. Enzyme induction is when you give someone a drug or a substance that will promote the a specific enzyme in the liver. It will promote its synthesis on the RNA level. They are going to stimulate the messenger RNA to translate specific genes for this enzyme. So this enzyme, if it's produced by abundance in your system, it will stimulate the metabolism of something. So it's like I'm waking up the beast. I'm giving them, for example, carbamazepine. I gave this woman carbamazepine, okay? So carbamazepine is going to increase the mRNA for specific liver enzymes. It will be produced greatly. So this enzyme work on something, right? So this enzyme will work on many things. One of them would be the COCs. So if I give her COCs, it's just like I'm not giving her anything, because the enzyme that is responsible for the metabolism of COCs is active, alive, and abundant in her system. So once she is going to take the COCs, she is going to have a fast elimination of COCs from her system. So this woman is going to be pregnant very soon, thanks to you. Okay, this is how it works. So enzyme induction or enzyme inducing agents, because they stimulate the enzyme synthesis, okay, in the liver, they also can increase their own metabolism. This is for your general knowledge, not only other agents. So in short, from giving this woman enzyme-inducing anti-epileptic drugs, okay, and I give her specific kind of contraceptions, mainly the estrogen-containing contraception. What I'm doing to this woman, I'm just making her believe that she is taking contraception while in fact she's not. Okay, because I'm giving her the contraception and something that causes degradation of contraception. On the other hand, we have lamotrigine. Lamotrigine work differently than the other agents. How is this? Lamotrigine, when it's taken with estrogen-containing contraception, it's not going to cause estrogen fast elimination from the system, or increase the metabolism of COCs. No, the opposite will happen. Estrogen-containing contraceptions are going to cause fast degradation of lamotrigine and decrease its action. So they are going to cause us increase in the incidence of seizures. Okay, this is a very possible exam question, and it appeared before in part 2, I think, if I'm not wrong, so it can appear for you because it's unique, and you know that our college loves the unique points. So in case of lamotrigine, estrogen-containing contraceptions are going to cause fall in the levels of lamotrigine and can cause increase in the potential of seizures. Okay, not like the other agents. Okay. Um, Here we are with the anesthesia and the dose, how to calculate the dose for local anesthesia can come to your exam, of course. Lidocaine, what is the nature of lidocaine? It is a mild local anesthesia. It is also class 1 antiarrhythmic drug. Take care because I have seen wrong answers within recalls. It's not class 4, it's class 1. The maximum dose for lidocaine with or without epinephrine is exam question also. With epinephrine, it would be 7 milligram per kilogram. Without epinephrine, stick, or let's say concentrated. So it would be 3 milligram per kg. According to the PNF, which we are relying on, the maximum dose is 200 milligram for adults without epinephrine and 500 with epinephrine. Take care because the doses are different between literatures and resources. So this is why I wrote it from the PNF. We can use it locally, of course. We can use it for paracervical analgesia or udendal block. So for udendal block, usually we use the 10 milliliter of 1% solution. So the total dose that can be used here is 100 milligram. For paracervical block, again, it's 10 milliliter of 1% solution. 1% solution means we have diluted the lidocaine in saline. General anesthesia in your exam is not a common question, but you should know what are the agents that can be used as muscle relaxants and the initiation of anesthesia. Which one is short acting, which one is ultra short acting, and the side effects. That's it. So the most famous one in our practice is, of course, the thiopentane or thiopentone sodium. We also use propofol, but mainly thiopentone is the most common one used in UK.